guarantee, because you can hook up an IV line, if you're not watching it, blood will backtrack into that bag. So you're better off with it on a pressure bag, and then you can regulate it with the roller can.
Do they have to still be connected to the dialysis machine?
No, they're going to be, you know, so basically you're going to take this patient, and you want to treat it, and you want to give meds. If they are still hooked to the dialysis machine,
I feel like they never are when we get there.
yeah, they usually not. But say like, because if you're running a code on a dialysis machine, the first thing we usually want to be doing is someone is going to be trying to chase that blood back, okay? And then, because the ideal place for doing a code in the dialysis unit is actually on the floor. So we train to drag the patient to the floor for people, because the chairs don't really flatten out. I've tried to do the board, I mean they're big, it's a nightmare. So usually what we'll do is we'll prime an IV line when they're in the crash cart that we have, and we'll just keep one attached, and we'll just have a syringe on the other side to keep that clean, and we'll start CPR. And hopefully, if they are doing CPR, they're getting the AED on the patient, and they may have even shocked the patient.
So if they hook it up, like there's just a saline line, like
yeah,
we can.
But otherwise, if that hasn't been done, if there's just syringes hanging there, the safest way for you to deal with that line, for less chance of infection, less chance of air going into the patient, less chance of blood coming out of the line, is if they lock off one of the lumens and only one lumen is left, and you have a nicely primed saline bag with a pressure bag, air expelled, and that way you can control how much you're giving with the roller clamp. And the reason I say the pressure bag is you don't want blood backing up, and you don't want to run the risk of air going into the patient. You're never going to just open that up wide without someone watching it, because I'd say no more than 500 mils bolus at a time on a crashing patient. Okay, and then reassess, and then see if you can get some more. You have to give volume. If the blood pressure is low, you're going to give that volume, and you're going to worry about fluid overload afterwards, because you will treat them with CPAP, or if they're coding, you're going to have them tubed, and by the time they get to the ER, they will worry about that, because then if we need to put them back onto dialysis, we will. But now we've got the help of inotropes or vasoactive meds. So
is the unit going to have access pressure bags, or should we bring our own?
Bring your own. That's what I would recommend. Bring your own. And if you haven't got one, you should have one.
We have one in the wall,
have one in the
but
wall.
it's not.
We don't always like routinely bring it in.
I just think it's the safest way. I mean, if it's not there, just at least when you get into the the ambulance, put it on.
Have one of the firefighters squeeze.
Yeah. Oh yeah, I'll have someone squeeze it, because you will see blood back out from some of those. And the big thing is get the air out, because I tend to think you accidentally ran a bag in and some air goes into that patient. So, because it will suck straight in, because that catheter I'm going to show you basically sits straight into that atrium. So, and that heart's pumping, and all it's doing is pump, pulp, 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 pulp. Or, depending on what lumen it is, or there could be blood being pumped out the other way.
If you're getting meds through that, and
so
it's kind of doing this.
Well, that's why you're going to use your roller clamp, so you can flush your meds in as well. And that's the other beauty about it, is now you can just do a rapid flush and just open up your roller clamp, and you get your meds pushed in quickly to the patient. It's just a safer way to do it. I thought about it and I thought, you know what, get it on the line. Then you're not worrying about any kind of cross-contamination by accessing, and you're not touching that line now. All you're touching is your IV bag, and that's what you used to do, pushing meds in through that bag.
You bring them in as a record, have them.
Yeah.
Are they prepared to do that? Will they just write it?
They probably won't, because the unit's so busy. It's insane. I'm just telling you, it's insane. The idea of like leaving the unit with all that, because meanwhile, all the craziness is going on. Because if it happens at turnaround as well, oh my gosh, it's unbelievably busy.
But it's always packed in there when you go in there.
Yeah. You have 30 minutes to basically get a patient off, turn around that machine, strip it down, clean it, get the next lines on, primed, and get the next patient in. And some of these patients are in wheelchairs. So you're boogieing. You're in a sweat. So if it's fistula, big thing about fistulas, I'm going to show you the needles. In fact, I'm going to hand them out. Like this.
We know we have like 15-ish minutes.
Okay, so this is the nitty gritty. So basically, catheter, that's where it sits in the heart. Okay, shouldn't go down through the valves. So I'm going to pass it around. These are the accesses on the catheter. The yellow one caps are what we're using now, called T-gauze. This is why we don't really need to use heparin anymore. They basically, we clean the end of it. We don't even take this cap off. We basically change it once a week, but then in between, we clean the end for a minute with alcohol, and then we can pull back because usually there's a clot inside here, because this isn't part of the general circulation. Once it's not in use, it's stagnant. So if any blood has backtracked through, we don't want it clotted up. We'll pull back about 10 cc's, then we will vigorously flush with a 10 cc catheter, and then we will hook them up to the machine. So if you were desperate and you're running a cord in a dialysis patient at the home, you've got no IV access, and you can't get an IO, and you had to use this is what you're going to do. You're going to really just vigorously clean that with an alcohol swab, have a clean piece of gauze underneath. You're going to attach a 10 cc syringe. You're going to pull back 10 cc's. It mightn't necessarily pull back. Don't stress about it, because quite often we can't pull back on these, and we just flush it with 10, but we always attempt it. And then you're going to hook them up. And then again, hook your saline bag. But that's where that sits. Okay. And then dialysis needles.
Wait, Marina, tell me the name of that again.
That's the CVC, that's the central venous catheter. That's the permanent spare.
Okay.
So I'll get these out, don't stitch yourselves with them. This is to give you an idea of what a dialysis needle looks like. Take the cap off and have a look, and that's the average size needle that we use. It's a 15 gauge.
That's the same size as an IO, just to let you know.
So you can have a look at these as well.
Up close and personal.
Right out through your finger.
Yeah.
Don't put it in your finger.
Yeah, I was going to say, you got them. You can have a look at one if you want.
Work better if they're spring
Hey, you
loaded.
guys, I forget, aren't there specific ports that we can and cannot access? And
But that's what I'm saying, but if you're stuck and you're coding a patient and,
Just don't
I don't know,
need PTSD.
otherwise you're going to, and you can't tube that patient, and so you can't give meds down the ET
we
tube.
can't anyway.
Nope.
Oh, so you
Not
can't give
allowed.
down the ET tube anyway. And so if you're absolutely desperate and you're trying to code that patient, you know, at that point it's a moot point about you're trying to save someone's life. So pull back 10 cc's, flush hard with 10 cc's after you've really vigorously wiped with alcohol, and then you're good. And the big thing I would always recommend is a saline bag, because as you can see, you could easily introduce air into that line.
Oh, yeah.
Pull back.
Okay.
So always yellow and blue.
Yeah, and it doesn't matter which side. Oh no, they're usually both yellow.
Oh.
The only reason I showed you this is to show you this is the kind that we used to use. This is a regular cap. That one you would have to take off. The yellow one, you never have to take off.
Just clean it.
So what makes that safe is you know, if you accidentally like have a clamp open, blood's not going to start flying out. The blue one, if you had that cap off and this clamp's open,
Yeah.
it's either going to suck air in or it's going to pour blood out at you. So it's an actual safe feature, so hope that they have these on. They should do, unless they come from the hospital and they might still have a blue clamp. But otherwise, yeah, just, and then always kind of saline bag, so then this clamp can stay open, and the way you control and flow into that patient is through your roller clamp and pushing drugs, so it's safer. So then the fistula needles, so these can come out if they're not taped down right. Your patient's diaphoretic, right? They're going into a shock type of status, they're probably gone really sweaty. You really need to make sure that this thing is taped down good. And if at that point you want to do circumferential, if that you really have a shocky patient or a coding patient, at that point you do want to maybe put a tape around, sure, but that's, don't like squeeze the life out of it, you know, just secure it tightly. The big thing with this is like, if you are given drugs through this and you take your cap off, you make sure your clamp's closed, push your drugs, always make sure you close this clamp. If you unhook your syringe and that, you're going to have blood everywhere. I mean, it's a bloody mess. So again, that's why I'm recommending, if you've got time, to have your partner get that saline bag ready on a pressure line, because again, this thing will fill a bag of blood, like a bag of saline with blood within a minute. It'll be full of blood. Because so, if you have your pressure bag and you accidentally have this open and the roller clamp open, there's no way that's just going to flush it there. And then you're not going to lose your medication into that bag, because if you're pushing medication and you're trying to flush it through, and now it's all back in that bag. So just be really mindful of using the clamp, because one of the dialysis staff had said about patients bleeding everywhere because the medics didn't realise to use that. You can always ask them to push the meds as well, but I would just do it yourself, to be honest. All right, let's whiz through. I know, because I'm taking longer than I thought. We started a bit late. I didn't realise it was going to take this long. So anyway, we talked about hypokalemia. That's
So is it something where like I mean, I feel like these are the patients that we'd be giving calcium to, or we should be giving calcium to.
That's actually, yeah, so actually I did skip that. So yeah, so basically you're going to want to do a 12 lead EKG. You can actually assume that they're probably in an acidosis. So you're going to be given bicarb. So you're going to be getting base orders. So you're coding a patient in dialysis unit. Start to think that maybe they're running a high potassium. If you've done your 12 leads, you can see it. I'll go through there. But basically, the things you're going to be asking for is bicarb and calcium. You guys unfortunately don't carry dextrose and insulin. That's what they'll be given when you get into the hospital if it is a hyperkalemia.
And are these for the patients that are in dialysis, or these for patients that miss dialysis?
It could be that either miss dialysis, but if a patient's coding a dialysis patient, you pretty much guarantee they're in an acidosis.
Oh.
So the coding, I would like to get your base orders. I'm pretty much sure they're going to tell you push that bicarb and push that calcium.
Yeah, would be worse.
Yeah. And then fluids help you do.
You gotta tell the patient.
But yeah, I mean, and yeah, if you found out they've skipped dialysis and say, oh, by the way, they skipped dialysis, you know, nurse thinks that, you know, they've got a high potassium, they've coded before that, they were chest pain, lethargic, weak.
Well, that's what I was gonna say, what about patients that are not coded yet, but they miss dialysis and they're not doing so good? Like, we used to have this guy in Los Osos, and that's what finally, but he coded like 5 times.
Well, it's pushing it.
You would miss dialysis.
Yeah.
We would
If
get
they're
very
Well, he's pushing the gambit.
brought back.
Yeah.
2 months later on him
Yeah.
again.
They're pushing the gambit. I mean, the chances are his potassium is high, he's
Yeah.
fluid overloaded, he's probably got pericarditis going on. He could be tamponading. Yeah. He is running out of it. Yeah.
Family wouldn't take it.
Yeah, so I used to have an alcoholic. He used to always think, yeah, you can take 10 litres off. And whether we could take 10 litres off 2 years ago, but now they've got such a huge body heart, they can't handle the 10 litres coming off. No, I can handle it. And you can argue with them, and you're okay. So we'll just do it, because you'll think, why did you do that to that patient? Because I was sick of arguing with the patient, and I wanted to prove a point that you can't handle taking 10 litres off anymore. Because it's literally banging your head against a brick wall until they learn that their heart has gone into huge failure. So yes, that's what I was talking about that. I was going to actually show a quick thing on hypokalemia, because you were asking about it, Myra. So hypokalemia basically is less than 3.5, general weakness, dysrhythmias, tends to be atrial flutter and bradycardia. So on a 12 lead, the T wave's going to be flattened out, and they might get a U wave. I've got pictures of that. They might have had excessive diarrhea and vomiting. They might have actually, their body in response to a high potassium will actually start doing that, and it might take them the other way. They might be using a lot of diuretics, which also, if they've still got urine output, it could be losing potassium. They're often associated with low magnesium levels. So if you've got an alcoholic, sometimes they will also have a low potassium. So it could be that. So you might see tossards with this patient when they're told.
But they're not always like peak T waves, right? Like,
No, this is going to be low, so
well,
it's
I
actually
mean,
not
like,
peak. It's
sorry,
going to be more
like
flat. Yeah, so hyperkalemia, for the most part, yeah, you're going to see peak Ts. It's progressive depending on how much
that's what I'm saying. Like,
potassium.
if it progresses to worse, then
Right.
it won't show. peak T.
Actually, yeah. So what happens is if the potassium climbs towards 8, the QRS starts to widen. P waves
Yeah.
all but disappear. That's the ones
that's
that
what
look
I
like
noticed. My
death.
patient, her
Yeah. They're the
it's
really
getting
like,
wider and wider and slower. And I was like,
yeah, these ones you
"Oh,
definitely want to be pushing that bicarb on and the calcium on. You're like, you're going to cord. It looks like almost goes to a tombstone. They're really difficult to defibrillate without lowering that potassium level. So unless you start lowering that potassium level, if you're actually shocking them, it's actually going to be hard to do anything with them until that potassium comes down. So that's where you want to be doing the calcium and the bicarb. You can also use some albuterol to help chase the potassium. You know, it might be that you can actually ask if the patient's, you know, not coding, but, you know, signs and symptoms, you've got a 12 lead showing high potassium, you might get a base order for albuterol. We usually do that, and the dextrose, and the bicarb, and the insulin. It's kind of like the little gambit treatment. You've probably seen that in the ER, right? Yeah. So here we go. 12 leads. Ignore the numbers, that's not actual for leads. So there you can actually see the U wave starting to happen if you look at like 1.7 for hypokalemia. And then hyperkalemia, like 9, where's the QRS? Gone. Then we've got twin peaks of it. There's the T and the QRS are pretty much matching out. Okay, anything, usually we used to say like anything where the T wave is like half the height of the QRS, you're pretty much looking at it. High potassium. And then that's the U waves and a hypokalemia, so right before the T. So pericarditis, the main thing to remember about this is T waves have become pointed and tall, but the gambit to remember with this, the whole thing, is all leads, it's contiguous in all leads that you will have the changes. Because sometimes people think they're having an MI, and they're not. It's pericarditis. Okay.
And our monitors will probably show us MI too,
Yeah.
right?
Yeah. Yeah, so if you've seen it, because it might be suddenly you think, oh, hold on, it's happening on T-waves. And even ER doctors have skipped this and gone straight down the MI pathway when they receive the patient, and they take another look at it and they suddenly realise, no, pericarditis. Or they get them to French and the cardiologist goes, it's not an MI. And they get egg on their face because now it's in all 12 leads. You know. So. Air embolism very rarely happens, but if it does, it's because the detector maybe wasn't inserted correctly in the dialysis machine. We're washing the blood back to the patient. Saline bag that we're using to wash our blood back empties, or there's maybe it's like somewhere something wasn't screwed on tightly and the pump is helping drive air into the machine. Patient will get basically an air embolism. So only seen it a couple of times. Signs, symptoms, shortness of breath, difficulty breathing, really complain of the chest pain. That's what they're going to say. And they often have that impending doom feeling as well. And they get very confused. They'll dump their pressure. And it's really bad, yeah, they're going to go bluish. So the treatment for that until you get to the ER is you're basically going to have them on the left side. You want that atrial and ventricular chamber to be up so the air floats up there. And just give them oxygen and try and keep them calm. Hemolysis, just quickly want to go through this. Again, you might get called to the unit if there was a mass hemolysis reaction going on. This is where the blood's come into contact with chlorine. I just wanted to touch on this just so you know what it is. Basically, the blood cells self-destruct. They've come in touch with contact with a toxin, they don't like it, they rupture. Basically, the patients are going to get really painful pain. They're going to start having clotting problems all over their body. And what we do is we basically stop dialysis straight away. We don't even give them their blood back. There's a detector will go off in the machine recognizing that there's a blood leak as well. The blood will change colour as well, it'll go like a cherry colour. We just give them lots of normal saline and get them to the hospital so they can monitor them.
Are those the patients that get like the erythropoietin or?
Well, all the dialysis patients get EPO.
They do.
But this is just something that might happen if for some reason, say like they use a carbon tank, and say like one of the monitors at the unit that's monitoring the quality of the water fails. And then suddenly where an alarm would have gone off and said, hey, there's chlorine in the water. It's not there. Because the carbon tank suddenly dumps all that chlorine because it's met its capacity. That's now in the water. You get a surge, it comes into contact with the patient's blood. I've seen it like a couple of times, and all of the patients start coming down. It's like a chain reaction as they all come into contact with it. And you think, oh no, we've got an hemolysis going on, and you find out, we go manually test the water, yeah, it's positive for chlorine. So it's usually why it happens. Yeah. All right, and that was, I think are we good on that? Because I just wanted to can I do quickly on ports? Are we good? Because that's going to do a little bit. Are you guys?
I'll offer more CEI. We're good, right? Am I right?
I didn't realize how long this was actually going to take. I just kind of.
Yeah, she's gonna take some, she's on her way, but.
The next bit shouldn't be long. It's just a quick review of some of the other accesses that you might see.
Are you good?
Yeah.
Is it been good? I mean, is this kind of information that's been useful? I know, I was really trying to keep it simple as well, because I've been really going into depth on some of this stuff. I was trying to be good.
Basically, if I ever have one failure.
Yeah.
I'm ready.
Take care of your kids.
So I know you guys come into contact with other types of IV access now, and in the last few years, I know that you're starting to see PICC lines, and I know there's been questions about those. So basically, why do they use these types of IV access? basically you have patients on chemo,